Let's start with a reality that every practice administrator already knows. Your medical practice is not getting paid what it is owed. The missing money isn't the result of fraud, and your billing team isn't necessarily doing anything wrong. The healthcare reimbursement system itself is structured in a way that allows money to quietly slip out the back door. These losses happen as underpayments, a missed contract provision, an unapplied modifier, or a fee schedule that simply hasn't been updated in your system. It happens without a red flag and without an error message prompting you to fix it. Many providers treat this leakage as an unavoidable tax on doing business. Writing off that revenue is a mistake. It is a systemic gap, one that most standard, high-volume billing teams simply lack the dedicated time or resources to close. Take a look at this bar chart visualizing hospital underpayments. In 2023 alone, Medicare and Medicaid underpaid U.S. hospitals by exactly $130 billion. When we add a trend line tracking from 2019 to 2023, you can see these underpayments growing at an average rate of 14% every single year. Right now, Medicare reimburses hospitals just 83 cents for every dollar they spend on patient care. Shifting this chart to commercial payers reveals a similar deficit. Providers are losing anywhere from 1 to 11% of their net revenue to underpayments from private insurers. Consolidating this data into a final comparison chart shows the cumulative industry impact. By 2025, provider organizations lost $48.4 billion to final denials and uncollected balances, a 25% spike from the previous year. Billion-dollar hospital networks are losing tens of billions annually to the payers. For independent, mid-sized practices dealing with the exact same mechanisms, those metrics translate directly into real dollars disappearing from your monthly collections. This flowchart illustrates policy drift, the operational log between when a payer changes coverage rules and when a billing team actually catches up. Expanding this update milestone reveals over 900 health insurance companies frequently issuing simultaneous updates to coding guidelines. That massive volume of changing rules directly drives up clinical initial denial rates and creates continuous fee schedule underpayments, as internal billing teams struggle to track every payer's specific quirks. And those internal teams are stretched thin. This pie chart shows the annual turnover rate for medical billing staff has reached 32%. For smaller practices, that turnover climbs past 38%. Every time a billing specialist leaves, they take vital institutional knowledge with them. Relying on an understaffed rotating pool of generalists to fight well-funded, highly sophisticated payers guarantees your revenue will continue to leak. The alternative is to assign the entire underpayment recovery function to a dedicated external team, one that works directly inside your practice's own electronic medical record system every single day. This is not a job for generic billing staff. To successfully catch bundle code errors and navigate complex compliance audits, this team requires specific, specialized AAPC and AHIMA credentials. This funnel demonstrates AI augmenting human expertise. An AI filter sorts raw claims, pushing high-value cases to the top. Automated audits then cross-reference the data in a digital ledger. Any mismatch between contracted rates and actual payments instantly triggers an alert. Moving to this model happens fast. It starts with a kickoff call to map your EMR. Secure VPN access is established within 48 hours, and the team goes live with a risk-free pilot in exactly 14 days. Combining credentialed human specialists with AI-automated EMR workflows eliminates the reliance on fragile institutional memory. It creates a permanent, leak-proof system. The text on this layout highlights the ultimate benchmark in healthcare billing. Industry research shows that organizations with dedicated revenue integrity programs report a 68% improvement in their net collection rates. Building an internal team presents a major financial barrier. An in-house full-time equivalent costs between $55,000 and $75,000 a year before benefits. But with the Staffingly outsourced model, a fully credentialed dedicated seat costs exactly $399 per week, dramatically outweighing the in-house expense. There are no long-term contracts. The team arrives already trained, skipping the 2-month ramp-up time and going live in 14 days. The reimbursement system guarantees that every single medical practice is leaving earned revenue on the table right now. The only choice left is whether you will deploy the specialized system required to take